This is the first nursing rounds for 2018-2019. And as some of you know, we have in past years held this at 8 in the morning on the fourth Tuesday of the month. So this is our first trial of holding it at noon on the fourth Tuesday of the month with complimentary pizza. So far so good. And we're really thrilled to have both Emily and Emma here to share their expertise on cannabis within the nursing context, because of course it's a very timely topic today with this month having been legalized in Canada. And so I'm not going to say too much other than that Dr. Emily Jenkins is obviously an assistant professor here in the school, and she does work in areas related to mental health, substance use, and public policy, and particularly around youth and including their voice in policy development. And Emma Garrod is an MSN student at UBC, and she's also a clinical nurse educator in substance use, the urban health program at the Providence Healthcare. So we're really thrilled to have them both here to speak to us on this a really important topic.
Thanks, Millie. All right, so we're almost 1 week post-legalization, and we are all still here to talk about it, which is exciting. Our world did not implode, despite some of the warnings. So we're here to talk about cannabis legalization and the implications that it has for the nursing community. And if I can figure out how to...
just click on the screen once.
Okay. Perfect. Okay, so I wanted to start off with a brief overview so you know what you're in for. I'm going to talk a bit about cannabis use trends in Canada, moving on to a quick discussion of health implications as we know them, providing a bit of an overview of the historical context of cannabis policy in Canada to set the stage for a discussion about legalization. And then I'm going to hand it over to Emma, who's going to talk about a number of the various implications for nursing. So what does cannabis use look like in Canada? Well, it's very common. In fact, behind alcohol, it's the most commonly reported substance used by Canadians. Almost half of our population reports having used cannabis in their lifetime. 12% of Canadians over the age of 15 years report having used cannabis in the past year. And use tends to peak during adolescence and early adulthood and then tapers off in the later years. There are some gender differences in cannabis use. This is for you, Dr. Olaf, with men reporting greater levels of past year use compared to women. Well, BC has quite the reputation for cannabis use, known as having prolific use, and indeed 2015 data indicates that we have the highest levels of use in our country. 51.3% of our population identified using cannabis in their lifetime, and 17.3% reported cannabis in the past year. So as you'll see, it's quite a bit higher than in some of the other provincial contexts. Youth cannabis is one of the primary concerns that we talk about, and so I thought I'd delve a little bit deeper into some of the youth trends. Cannabis use amongst youth has actually been on the decline over the last decade and a half. Data from the McCreary Centre here in BC indicates that between 2003 and 2013, cannabis rates amongst youth actually dropped by about 11%. This is some national data that reports cannabis use by grade, which is a nice proxy for age. You'll see here the dark blue bar, that represents the youngest cohort, grade 7s, who were included in this survey. And the orange bar represents the eldest cohort, grade 12s, who were included in this survey. So you'll see that cannabis use tends to increase with age, which isn't that surprising. And by grade 12, about 43% of our youth report having used cannabis ever. About 33% report having used cannabis in the past year. About 23% report having used cannabis in the past month. And about 5% report daily use. And so while 5% isn't a very big number, it is one that we are concerned about because that early and frequent use is what is associated with the greatest harms. And so what are the harms, and for that matter, benefits of cannabis? You've probably all been introduced to claims, some of them quite inventive, about the harms and benefits of cannabis use. But we actually don't have a lot of conclusive evidence of the risks or benefits. If you're interested in this topic, I would suggest checking out this report from the National Academies of Sciences, Engineering, and Medicine, which was released in 2017. And in this report, they collate and report the results of over 10,000 studies, and they conclude that there's no conclusive evidence to support any claims, but there is substantial evidence to support a handful of risks and benefits. In terms of risks, there's substantial evidence to support a link between the onset of schizophrenia or other psychotic disorders and cannabis, but the nature of this relationship is quite complicated. This is tended to be concentrated amongst young people who have another risk factor or genetic predisposition to a psychotic illness. And so research is really needed to help tease out the nature of this relationship and inform our actions in this area moving forward. There's a relationship between motor vehicle accidents and cannabis use, obviously due to the impairment that cannabis causes. Cannabis use amongst pregnant women has been associated with low birth weight. Cannabis use is associated with a whole host of respiratory problems, in particular chronic bronchitis, and generally among people who are heavy or long-term users. And certainly there's substantial evidence to demonstrate that when cannabis use is initiated early and used frequently, that it's associated with problematic use and cannabis use disorder. In terms of risks, again, we haven't had the ability to really explore this area in great depth, and part of that has been due to the legal status of cannabis, which has served as a significant barrier to being able to conduct research and really explore use patterns and possible treatment modalities. But we do know that there is treatment efficacy for cannabis use for chronic pain. It has been effective in the treatment of nausea for patients with cancer, and it's helpful in reducing muscle spasms among those with multiple sclerosis. So I think it's fair to say as a research community we're quite excited about the prospect of being able to explore these health implications much further now that cannabis is legal. So the key messages that I'm really hoping that you'll take with you today around the risks and harms is that most people who use cannabis do so infrequently and do not experience harms. That use tends to taper off with age, and that there's increased risk for harms when cannabis use starts early and is used frequently. So now I'm going to give a brief historical overview of the policy context that has been in place for the last several decades, the era of prohibition, before moving on to talk about legalization. So cannabis policy has been debated really since it first became illegal in 1923. And we're not really sure why it was added to the list of scheduled drugs at that point in time. There's no documented parliamentary or Senate debate. And so we're left to hypothesize. And one of the hypotheses that has been put forward is that the work of Judge Emily Murphy was quite influential. She, at the time, wrote a book called The Black Candle. It included a chapter on cannabis and linked cannabis use to unsavory populations and races. And so there's this notion of the historical racial undertones of prohibition of cannabis in Canada. And interestingly, cannabis really wasn't a problem at the time. In fact, the first seizure of cannabis took place over a decade after these laws were put into place. Fast forward several decades, and in the late 60s and early 70s, there was increasing concern about recreational use of drugs, particularly among white middle-class kids. And the concerns grew out of the fact that these young people were receiving criminal records for their drug use, and that these criminal records had implications for their ability to secure meaningful employment, to travel, and that it was created stigma that meant that many of them didn't seek help when needed. So the Government of Canada struck the Levine Commission, which in 1972 tabled a report that called for the decriminalization of all drugs. It was the first time in our history that we really see this support for federal drug policy change around cannabis, but of course it was unsuccessful. We wait another several decades, and in 2001 we get the medical access regulations, which allow for the medical use of cannabis in our country. And later that year and earlier the next year, the Senate and House of Commons call for legalization and decriminalization, respectively. Between 2003 and 2006, there were multiple attempts at decriminalization, so there was great hope at that time that that was the direction that we would be moving. And then in 2006, the Conservative government was elected. So you all know what happened then. We were on hold for over a decade, and when Prime Minister Trudeau was running for his position, he ran on a platform that included the legalization of cannabis, and once elected, created the Task Force on Cannabis Legalization and Regulation, which culminated in the legalization of cannabis on October 17th, 2018. So legalization represents a public health approach to cannabis and can be contrasted with a criminalized approach or prohibition that we've been living in for the last almost 100 years. And before going any further, I wanted to provide briefly a definition of these terms, which I've now used several times and which I'm sure you've heard of as we've been moving towards this policy change. And I think they're often misunderstood, so wanted to just bring some clarity. Legalization, which is what we've just adopted, addresses both the supply and demand side of the market, bringing production, distribution, and sale under the control of the government. It's an effort to minimize risks for contaminants, for example, and be able to control concentrations and things like that. Whereas decriminalization is kind of a half measure. It addresses the demand side of the market by removing criminal penalties, but the production remains in the black market, and we do not have control over what gets produced and then therefore distributed. Decriminalization is the more popular approach that has been adopted in many jurisdictions throughout the world, including some of the U.S. states, and we'll talk a bit more about the U.S. states in relation to another point later on. So the public health approach is put forth recognizing that there's a spectrum of psychoactive substance use in really all societies. It's occurred since the beginning of time. We're not really going to be able to stop that per se, but we can focus on problematic use and chronic dependence where our harms are concentrated. And so that's what we're attempting to do with legalization. The rationale put forth by our government for legalization is threefold. The first is to keep cannabis out of the hands of youth where we know it's prevalent and where we know if it begins young enough there, it's associated with those harms we were talking about. Number two is to keep profits out of the pockets of criminals and also to acknowledge the negative implications of criminalization. This builds on evidence that we have that indicates that about 50% of our drug charges are related to cannabis alone, and that of these, about 55% are for single possession charges only. So the effort that goes into criminalizing cannabis really makes no sense. Also, historically, the laws have been applied differentially to different populations. So those from racialized and indigenous communities tend to be charged more. As I mentioned earlier, it's associated with difficulties with employment, travel, stigma, treatment, etc. And it hasn't seemed to have any impact on reducing use or harms. And so finally, the government has said that they want to better protect the public health and safety by allowing adults to access and use legal cannabis, and they have control of that market. So this is a conceptual model of various cannabis policies and harm. And you can see on either end of the spectrum, we have increased level of social and health harms. So under prohibition, where we were operating, we've got harms related to an unregulated criminal market. And at the other end of the spectrum, where you've got legalization without regulation, we have an unregulated legal market where where it's really private industry that's driving that element of cannabis production and distribution. And that's what we have in many of the U.S. states that have legalized. And so it's that model is associated with significant harms. So Canada, with their legalization and strict regulation, is intending to try and minimize harms on a public health model. So before, or as I end my portion of the discussion, I just wanted to share some insights that were shared with me at a recent drug policy conference where we had a fellow Steve Rolls in from the UK. He's a drug policy expert who, in the midst of Canadians kind of critiquing our move towards or our particular approaches to legalization and arguing that this was a good move, however Canada might not be ready or we might be doing it wrong, he was really able to kind of situate the magnitude of this event by saying that, reminding us that Canada is the first G7 country to move forward with legalization, and that by doing so, we're breaking a number of UN drug treaties. So it's a really big deal, and the eyes of the world are on us. And so it's going to take some time for us to work through the challenges and to get this right, but that it's much easier to kind of open up our policies a bit more as opposed to tightening them up. So a really monumental policy shift that we are living within right now, and exciting times, I think, for all of us. So I'm going to hand this over now to Emma, who's going to take us through implications for nurses.
Hello. Thanks, Emily. There's a couple hot seats in the front if anybody wants them, or it's up here. How do I do this? Just on this? Down. So as Emily mentioned, we are sort of just entering this process. I flew out of the country on October 17th, which I thought was kind of funny timing. I was like, what? What am I going to miss? So I don't know if there's anything kind of monumental that happened, but I think it's really going to unfold over time. As she mentioned, there's not been a ton of research done on cannabis, partly because of its status as a controlled substance. And in healthcare, I think we're going to do a lot of learning along the way. So I'm going to talk as best I can about implications for nurses, and I think these things will continue really to shift and evolve over time. So one piece that I think is really interesting for us is really kind of having more of a grasp on what drug policy means for the people we work with, and how that sort of criminalized factor can intersect with the determinants, social determinants of health. So obviously this is shifting. The rates of charges for possession of cannabis, that's going to shift over time, but other substances that are illicit still continue to be criminalized, and sort of those processes really affect the lives of the people we work with, especially more marginalized populations. So I think it's really good to have that framed in our minds as we work with people, understanding those factors. So I'm going to go a little bit through what cannabis is and how it works in our body. So cannabis is a plant. It's a botanical that humans have used for over 5,000 years. So there's evidence to suggest we've been interacting with this plant for a long time, and it was indeed used as a medicine, first described in the United States Pharmacopoeia for the first time in 1850. So we have used it previously as a medicine, and then it became a controlled substance. So there's a few different plant species. I'll talk a little bit more about sativa and indica. Sativa is the tall one. It tends to be more stimulating and uplifting, so exemplified in the shape of the plant, and indica is like more relaxing. So it's kind of interesting that the plants themselves sort of embody those characteristics. So it's usually a plant-based material. Sometimes the leaves are what is considered like the bud or the flower of a plant, or some of that resin from the flower can be compressed into something called hash or hashish, and sometimes into oils. So cannabis is a scientific name. We also refer to it as marijuana. Can anybody think of other names that are used for this plant? Weed, yeah. Shake, pot, yeah. There's like so many names, and there's lots more names that are kind of continuing to come out, especially as synthetics are developed as well. So people consume this in many different ways. Often the dried flower or hash is smoked, so in joints, that would just be rolled up straight smoking of that, or through water, sort of via water bungs, can sort of make it more, sometimes more easier on the lungs. People are also starting to vaporize a lot more, so that's where people won't be inhaling burning chemicals, but more of like a water vapor. So again, we don't know a ton about the health implications of that, but how people are consuming it is shifting. People also eat marijuana, so sometimes things are baked, and sometimes they're reduced into their chemical components and put into things like gummies, etc. And tincture, so that would be either in an oil or an alcohol base. Now, how we consume things really affects how the onset and the duration of substances. And so this matters a lot when it comes to how people consume and how we might want to talk to our patients or provide education around that, and on sort of sometimes negative consequences. So I had the opportunity to be in St. Paul's Emergency Department on a 420 one time, and huge volume of folks coming in, and a lot of people had taken edibles. And because that takes a lot longer to kick in, also it can just taste like candy or cookies, people may take more because it tastes good or they haven't felt the effects yet, and then all of a sudden they're hit with like an incredible wave of sometimes the negative effects. So cannabis can affect people quite differently, and that depends on if people have tried it before, and again, our own host of our very complex brain chemistry. So there can be sort of euphoria, elation, increased sensory perception, sometimes increased appetite, and there can also be negative effects, and anxiety is probably the most commonly reported one. Negative consequence for people, or sort of sensory disturbance, like that being kind of an uncomfortable experience, and nausea and vomiting, especially with those higher doses and especially with things like edibles. So what is acting in cannabis? So what's really interesting to think about when we talk about this stuff is our bodies actually have our own endocannabinoid system. So we produce our own type of cannabinoids, and one of the main ones is called anandamide. And we also have receptors throughout our body that actually fit and interact perfectly with some of the components. So in the resin are things called cannabinoids, and those are the chemicals that we absorb into our bloodstream, no matter which way we consume it. The main one that was kind of first found and is generally considered to have most of the psychoactive properties is THC delta 9 tetrahydrocannabinol. Sorry, I have to read that one. It's quite long. And so that is what's considered to have more of the psychoactive effects, euphoria, relaxation, or anxiety, and has some of the effects on memory. We're starting to pay a lot more attention to something called CBD, or cannabidiol, which is another component. And it is something that's being found to maybe mitigate some of the more negative effects of THC. So when it's present in the same cannabis that someone is consuming, might sort of mitigate some of those effects. Is also being studied for some really interesting, like, immune properties, anti-inflammatory properties. So as sort of restrictions start to lift, I think we'll start to see a lot more research with this substance as well. In terms of where they land in our bodies, so we have two main receptors, CB1 and CB2. CB1 mostly through the CNS. That's the lighter blue that you can see there. And then the darker blue is CB2, so receptors mainly in the gut and more peripherally and throughout the immune system. And so THC is thought to mostly act on the CB1, so more within our central nervous system. And yeah, so this is like, it's just a really interesting thing to kind of remember that we also have our own like endogenous cannabinoids, and that our brains are kind of designed to work quite specifically with these chemicals, which isn't the case for all substances. So working differently, again, THC fits quite perfectly with the receptor and has psychoactive activities when that happens. It also affects the release and sort of uptake or release of dopamine, and so does work along the reward pathway, which can be something that does, with repeated use and with complex brain chemistry, lead to some of those effects that can be related with dependence or sometimes even withdrawal, so more compulsive use. Whereas CBD doesn't have, like, it exerts its effects without having some of that sort of same psychoactive or properties that work along the reward system. So people can use cannabis recreationally and casually. People can also become quite dependent. it's rare, and even rarer is a withdrawal syndrome, but it does exist and occur. And most people won't see it unless they work like in a detox or something like that, but this can happen for some folks. These letters are really small. I'm not sure why I put this in, but just one thing to take note of is that THC concentrations have been increasing a lot. So we have a traditional reefer cigarette in the 1960s having about 1 to 3% THC, and now later having 6 to 20%, and some things actually are containing upwards of 90% THC composition. So when we consider a bit more of the sort of balance there might have been previously with THC and CBD, and some of those negative sort of outcomes that Emily was talking about. So just, again, part of understanding what's in the substances, and then, again, how we can talk to patients about it. So this is just a news article saying that likely low-potency products are what people are going to actually enjoy most as this legalization unfolds, and as we see perhaps more new users trying. Perhaps, we're not actually sure. That's not being really shown to be the case in other places that have decriminalized, but that people may overall tend to enjoy some of the lower potency products over these really high concentrations of THC, which can actually make people not feel super great. Another piece for nurses is how do these substances interact with medications we give patients, right? I mean, this really applies to any substance, but there hasn't been a ton of research, so there isn't much information out there, but this is a great website called drugcocktails.ca. It's listed at the end as well in resources. And so you can look up medications and then learn how alcohol, tobacco, cannabis, many other substances interact with those medications. So I'm not going to spend a ton of time talking about this, but this is there as a resource to support how we might talk to patients about these combinations. And really what all this means is that we can have informed conversations with our patients and help them make informed decisions around how they may or may not use cannabis. And so understanding the pharmacology and content can give us a little framing for that. We can discuss risks and benefits with people, the little that we know, right? And as Emily went through the evidence, we have sort of a handful of things that it can be risky with and a handful of things that we know that it can be helpful with. We can talk to people about dosing. I'll go through that in a moment, harm reduction, and really just thorough assessments to kind of keep the conversation going with patients, finding out from them what's beneficial, what they experience as beneficial, and also what might actually be harmful for them. So dosing, there's no specific science. Again, the concentrations vary so widely. There's different strains that make people feel differently. But smoking, the onset's much quicker, 5 to 10 minutes, and lasts about 2 to 4 hours. And people often recommend for first-time users, there's guidelines around how people may, best ways for people to start using medicinal or medical cannabis. It's usually like 1 puff of a joint once per day and then increasing from there. So pretty small amounts. So it's really starting low and going slow for people. Vaporization, similar. Oral, like edibles, taking 60 to 180 minutes for people to actually feel effects. So that's really a long time to wait to see how that's going to make you feel. So again, starting slow. Because it also lasts a lot longer, 6 to 8 hours. So you might not want to be feeling not great for 6 to 8 hours after you've waited 3 hours to feel that way. Topical concentrations vary. They don't really have much information. That oral mucosal would be the tinctures, a little bit shorter, 15 to 45 minutes, and also lasting 6 to 8 hours. So kind of in between the inhaled versions and the other versions. What I really like about these harm reduction principles is that they can apply to first-time users, and they can also apply to people who are really regular users of cannabis. And a lot of them really align with just regular harm reduction principles, and some of them are kind of specific to cannabis. So again, we were just talking about dosing, starting low and going slow for people, especially first-time users, considering appropriate time and place, so maybe not before work or school or driving or other activities that might not go well with that. Choosing less risky products, so considering things that maybe have higher CBD content, kind of considering what the breakdown is there. Safer methods of consumption, so they talk about not like inhaling and not holding it in the lungs, sort of like kind of taking smaller amounts, especially when smoking or considering not smoking and using other forms. Safer smoking practices, Also considering what it means to share joints if someone's sharing, those kind of things that sort of go along with how we consume things. Decreasing amount and frequency, so if someone's a regular user, and possibly if it's starting to become problematic, seeing if people can use less throughout the day. They recommend avoiding synthetics completely. So these are things like spice and K2 you may have heard of that have really, really high THC concentrations and have been linked to some pretty adverse events. So really just kind of steering people clear of those as much as possible. Avoiding mixing with other substances like tobacco and alcohol. Don't drive high. We've also seen the bus stop ads that essentially just say that. And considering the personal risk profile. So as Emily mentioned, people maybe with a family history of schizophrenia, these type of, complex risk factors that we know about, as well as if somebody is pregnant. And then kind of moving this into just like more of an overall assessment. This is a great opportunity for us to talk to patients about substance use more. And that's like the work I do. And I'm a huge advocate of just really having open conversations with patients about all substances. Now that cannabis has moved into the legal realm, people might talk to us about it more because substance use has generally been quite stigmatized, and people tend to sort of talk less about what they use. And so people might actually share more with healthcare providers about their use, which is great because it just means we can sort of employ all that we know to the best of our knowledge. It's nice to explore what people find beneficial about it, and people find all kinds of stuff beneficial, and that can be their own personal experience. And then we can also explore, hey, is there anything that's like not feeling that great about it, or maybe some consequences. So if someone was actually starting to move towards that sort of end of the spectrum of having sort of problematic use or substance use disorder, the DSM-5, Diagnostic Statistical Manual 5 criteria would also be applied in that same way. So if someone's starting to talk about not having as much control over their use, consequences, or cravings that are maybe not related to what they sort of use it medicinally for, those would be hints that they're maybe moving towards something that's a little bit more problematic. And then there's also people using cannabis as harm reduction. So some interesting research, I just got to see at a few conferences where people are using it to use less opioids. So in the context of the opioid overdose epidemic, some pretty interesting qualitative and quantitative sort of observational work looking at people who use cannabis having lower opioid use and people describing using it as a form of harm reduction. Yeah, that kind of links us into some of the contributors and effects, trying to get a, of course, holistic picture of what people are using and why. So some folks may use for pleasure or experimentation. Some people may use for more emotional coping or medicinal use, so something that they experience more physically, something like pain. Also conformity, so some of those social environments that affect why and how we use certain things. And then kind of what's it doing for people? So are people having some of those good feelings, the euphoria, the elation, appetite stimulation, or they kind of experience some of these other bits, panic, fear, trouble concentrating, and decreased interest in completing tasks. And sometimes people can have both. It's very complex with how it interacts with our system. The different strains work really differently for people, and a lot can depend on how frequently people use, their environmental circumstance, other things that are going on in their lives. So it's very difficult to predict how cannabis will work even in your own brain, kind of consistently over time. How is this going to work out in our healthcare institutions? We're not entirely sure yet, but a lot of the stuff kind of, we know that we can't smoke on hospital grounds, so that's still not going to be okay, smoking cannabis. What does it mean for people consuming edibles, like if they're consuming them or storing them in their bedside? It's going to kind of vary across institutions. I mean, generally people can't store alcohol or other psychoactive things, so it's going to, where I work, we do not have a policy on it yet. Someone's been working on a policy around pharmacies actually dispensing someone's own supply of medical cannabis while they're admitted. That's on hold right now, but these types of things, we might start to see them come in, and I'm not currently aware of any sort of specific institutional policies around either people storing their own supply of cannabis or pharmacies dispensing. But I'd love to hear from you all if you do know of any. Yeah. And again, sort of how we're implicated as nurses, we have varying levels of governance. So even how cannabis policy is being rolled out, we have the federal legalization framework, and then each province is kind of doing it differently. And then we're governed by our colleges, and then each institution, again, will have its own sort of set of principles. So it's going to be different everywhere, but it's sort of just something to kind of keep your ears open for. And I hope we get some good clarity for nurses coming up. And at the end of this, there's also a bunch of references listed that talks more in depth about sort of exactly like some of the ways nurses might work with cannabis. Occupational health is just what I'm going to end on. I received a really funny email at my work, just being like, essentially, this won't change anything. We are not supposed to work in pairs, so there's policy that says we can't have drinks at lunch. You know, other occupations do, as well as the sort of smoke-free policy that exists in all our healthcare facilities. So most institutions will already have policies that cover sort of these concerns and these sort of issues, potential issues with occupational health. So just because it's legal doesn't mean you can smoke on your break. Yeah, so not a lot of discussion there yet. But I think in other settings where people might have more restricted stuff around psychoactive use, it's going to apply differently in different occupational settings. And that's all from me. We have some amazing resources. So the Cannabis Talk Kit, how to talk with teens, and the sensible cannabis education toolkit for educating youth. A lot of this stuff is youth focused, but is really great information and resources for adults as well. It really breaks down a lot of this pharmacology into really easy to understand ways. The resource Emily mentioned earlier, so affects like sort of the current state of the evidence and resource. We have lower risk cannabis use guidelines as well. So lots of resources just to educate ourselves more in depth, as well as direct patients towards. Oh my gosh, you put all these pictures in here. So how to reduce more around harm reduction for non-medical cannabis use, cannabis critical thinking pathway for nursing practice, which talks a little bit about those levels of governance that I mentioned. And that's the end of the slideshow. And I'm back.